We'll get started. So I will take the opportunity to introduce Dr. Brian Ballios. I'm sure many of you know Dr. Ballios, but if there's one thing, I've known Brian a long time, and if there's one thing I know about him, he's an overachiever. So, I looked him up a little bit. I didn't know he had a background in material science and engineering chemistry from Queen's University, but that doesn't surprise me at all. And following that, he went on to do his MD and PhD combined program at the University of Toronto. And during that time, he developed the first injectable hydrogel-based delivery system for transplanting stem cells into the retina. And if that wasn't enough, he went on to Harvard to the Mass Eye and Ear to do a clinical fellowship in IRD. It's our privilege as a department to have been able to recruit him back, because I'm sure he had many people calling him, trying to suggest that he join their faculty, but he chose the University of Toronto. We were privileged to have him back. He's been a great colleague, working out of both Sunnybrook and UHN, as well as Kensington. And I look forward to the talk this morning. Brian, the floor is yours.
Thanks, Hamadip. That's for that very kind introduction. Well, we prepared, I think, some interesting cases that I hope everybody will be able to see some facet of their practice in that, even though the topic is, my specialty around inherited and rare disease. So Ryan's going to take us off with the first case and get us started.
Okay, great. Thanks, Dr. Ballios. So our first case today is called the forgotten genome. And I just like to thank Dr. Ballios for providing an interesting case, and also him and my co-resident Saba for helping to prepare the talk. So here we have a 50-year-old South American woman who's presenting to us from her primary care provider for diabetes screening. Now, she has a history of unspecified pigmentary changes in both eyes, but at this point, all we know is that she has type 2 diabetes, and she's presenting for a routine examination, and she's asymptomatic. From her optometrist, she was told she has early onset age-related macular degeneration, and there's also a history of untreated amblyopia in the right eye. So she has decreased vision in the right eye at about 2100, but there've been no changes since childhood, and she's asymptomatic. And the rest of her anterior segment exam is normal. When we look at the posterior segment here of the right eye, and then of the left eye, we do notice some changes. I'm just wondering if there's any residents there in the audience that might be able to just quickly describe what they see in these photos.
Maybe we'll go PGY3.
Anybody? Sonia, go ahead.
So it's a fundus photo of the left eye. The media appears clear. The optic disc appears normal. The vasculature as well. The fundus, the macula centrally looks okay, but when you look at the peripheral macula, there's some areas of modeling and hyperpigmentation.
Yeah, that's perfect. Exactly. So yeah, I totally agree. So the fundus itself, when you look at the fovea, that appears to have a normal pigmentation, but the perifoveal, the remaining of the macula, does have those pigmentary changes. And then you can even see, might be hard on the photo, but you can even see they kind of extend around the nasal disc as well. And what about the OCTs we have here? How would you describe those?
So for the OCT, we can see there's a normal control of the interretinal layers, and the macula look normal as well. But moving away from the fovea to the rest of the macula, there seems to be some hyperrefractive foci that's kind of at the level of the RPE and ellipsoid zone area. And then there seems to be some kind of after retinal layers atrophy as well.
Yeah, thanks, Van Long. So yeah, like when you look at the fovea, that appears normal. But as you go to the perifoveal region and look at those outer layers, especially in the left eye, you have very significant outer retinal atrophy. And one other test that you can have is FAF. And here you can see that, again, you have a normal hypo autofluorescence signal within the fovea. But as you go to the perifoveal region, you kind of have this very granular appearance of hyper and hypo autofluorescence. It surrounds the disc to encompass the nasal disc on both eyes. And you can really appreciate how symmetric this process is. It's almost a mirror image between the right and the left eye. And you also have these hyper autofluorescent cores, or these kind of radial projections of hyper autofluorescence that's quite unique and not something you typically see. So this brings us to our first poll question. So question one is, at this point, even though you have limited information, what would your top differential be? Would you say A, early onset age-related macular degeneration, B, more of an infectious cause, C, inflammatory, D, maybe a drug toxicity, or could it be a hereditary cause?
Okay, I think you've got 100% answer, which is hereditary.
I'm sure people are biased by the presenter as well.
Exactly.
So right now we're looking at more of a hereditary cause, which I think is a very reasonable thing to think. So we want to go into a bit more detail in her past medical history. So in addition to her type 2 diabetes, we find that she has a history of asthma, anxiety, migraines, constipation. Those are all things we, quite typically see in the clinic. But she also has a history of short stature, hypothyroidism, and these events that stroke-like occurrences or episodes where she develops hemiplegia, speech disturbance, word finding difficulties. And as part of the workup for that, through neurology, she had both CT scans shown on the left and MRI shown on the right that had basal ganglia calcifications bilaterally. And she also had a history of hearing loss beginning in her mid-30s. If you remember audiograms from medical school, you can look at air conduction and bone conduction. When you have a decrease in both, that points towards a sensory neural hearing loss. And here it's at the high frequencies in both sides, and it was graded as mild to moderate. So as part of her initial workup, could this be an inflammatory cause or an infectious cause? There was quite a bit of imaging and blood work done that came back normal. Could it be something like a burnt out VKH? She does have a South American ancestry, history of headaches or stroke-like events, hearing loss, chronic appearing retinal changes, but there was no poliosis, no vitiligo, and it wasn't really in keeping with VKH. Could it be an inherited retinal disease? Well, in that case, we want to get a more detailed family history. And here we find that the patient here is indicated in the green arrow. And we find that her mother also has a history of type 2 diabetes and hearing loss. Her older brother has type 2 diabetes. Her younger sister has type 2 diabetes and hearing loss. And through her sister, she has younger nieces and nephews also with type 2 diabetes. And there's no history of consanguinity. As part of her workup, she had Goldman kinetic perimetry that was largely normal, full field ERGs shown here as the rod isolated, rod cone responses and cone isolated responses were normal. And even on multifocal ERG, the central macular responses were normal with some reduction in the peripheral macular responses. So largely normal. So in summary, we have a 50-year-old woman presenting with a maculopathy in both eyes, has a very symmetric pattern-like appearance. It extends to encompass the discs bilaterally. There's foveal sparing with largely preserved visual function in the context of her amblyopia. She has an interesting history of type 2 diabetes, migraines, stroke-like episodes, sensory neural hearing loss at a young age with basal ganglia calcifications, hypothyroidism, GI issues. There's also a strong maternal family history of diabetes and hearing loss. So when we think of a potential differential, could this be something like an acquired cause, such as age-related macular degeneration, which she has been told in the past? Medications, such as Pitocin? Could it be a hereditary cause, such as ABCA4 related or one of the pattern dystrophies, or could it be something else? So this leads us to our second poll question. What do you think the most likely inheritance pattern could be for this presentation? And I've shown the pedigree here again. Do you think it's not inherited at all? Could it be autosomal dominant, autosomal recessive, X-linked, mitochondrial, or is it just too early in the morning for such a tough question?
We'll give it a couple seconds to run here. There you go. You got a bit of a split between mitochondrial and autosomal dominant.
Okay, good. So we did some genetic testing, and it was found that she did have a mitochondrial disorder. So before we go into her actual condition, I'll just talk a little bit about mitochondria in general. So we're more familiar with nuclear DNA. So we have our 23 chromosomes, approximately 3 billion bases, and in excess of 20,000 genes. In contrast, there is also mitochondrial DNA. And this is more circular. You have about 16,000 bases and 37 genes. And unlike nuclear genes, mitochondrial genes are derived only from the mother because spermatic mitochondria are rapidly degraded upon fertilization. So this means that children of both sexes can inherit mitochondrial diseases, but only the mother can pass on such conditions to the next generation. And there are also multiple copies of mitochondrial DNA within each cell. So mutations can affect either all of the molecules, which is termed homoplasmy, or some of the molecules, which is termed heteroplasmy. The level of heteroplasmy, or the mutated burden of molecules within the cell, can vary between tissues or organs. So it can vary between cells in the same tissue or organ, from organ to organ, or between individuals in the same family. And that's why you get such a breadth of presentations with a mitochondrial condition. If the mutation is pathogenic, there usually has to be a certain burden of it, called the biochemical threshold, before you actually detect a defect in the respiratory chain. And when cells divide, the proportion of mutated, which is red, and wild-type mitochondrial DNA can differ between the two daughter cells. So this can lead to an upshift or downshift in the degree of heteroplasmy over time. And then furthermore, mitochondrial DNA is continuously turned over at all points in the cell cycle. So even if the cell is not dividing, you have some molecules that are selected for replication, which is the arrow, and then some molecules are destroyed, which is the X. And this is called relaxed replication. So in both of these processes, you have changes in heteroplasmy over time. And mitochondrial variants can fall within a kind of continuous range. And here we have a plot that shows the allele frequency from rare to common on the x-axis and the effect size from weak to strong on the y-axis. So at one extreme, you can have variants that are causal for monogenic disorders. So you have very rare allele frequency. It's more heteroplasmic, but a very strong effect size, such as MELAS, which we'll talk about in a little bit. And on the other extreme, you can have those function as more of a risk allele for a more common and complex disease. So it's more homoplasmic, more common allele frequency, but a smaller effect size. And that could be something like Parkinson's, where you're at risk for developing it, but there's also epigenetic and environmental factors affecting the outcome. And then other variants can lie somewhere in between, such as Leber's hereditary optic neuropathy, where there's certainly a genetic component, but there's also environmental factors such as smoking that determine if and the degree to which it can present. So that's why you have such a broad spectrum of presentation in mitochondrial conditions, and it can vary on the organ system of how severe the presentation is. So when we tested our patient for mitochondrial disease, she was found to be positive for MTTL1, and her heteroplasmy level was about 27% in the saliva. So this is a pathogenic variant. So what is MTTL1? So that stands for mitochondrial encoded tRNA leucine 1. And this disease can be retina only, non-syndromic, or even an asymptomatic carrier at the very mild end. The most severe presentation is called MELAS, which is mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. And more commonly, it presents as MID, or MIDD, which is maternally inherited diabetes and deafness. Quite often, this can present in, or the symptoms can start in late childhood, early adulthood, and almost always before the age of 40. And it's due to a point mutation from A to G. And both the point mutation can cause MELAS and MID. So there's kind of an overlapping set of features. It can affect many different systems within the body. So the ones that our patient had are highlighted here in green. So she had strokes, cerebellar and some cerebral atrophy, hypothalamic with short stature, sensory neural hearing loss, maculopathy, diabetes, GI issues with malabsorption and constipation. And you can also have CPEO, myopathies or cardiomyopathies and arrhythmias, renal issues with glomerulonephritis. And interestingly, when they do CT scans of these patients, they often have those bilateral basal ganglia calcifications. Really interestingly, I thought, was that it's estimated that between approximately 1/2 to nearly 3% of patients with diabetes actually have MID when they do mitochondrial testing. This most often presents as a type 2 diabetes picture with patients with a normal BMI, but it can also present more as a type 1 picture with diabetic ketoacidosis. And this is because ATP that's generated by mitochondria is important in glucose regulation because it opens up potassium channels. So potassium moves out of the cell, calcium moves into the cell, and that stimulates the release of insulin. So if you don't have sufficient ATP production, you're not getting sufficient insulin release, which affects your blood glucose levels. And that can also eventually lead to apoptosis of beta cells within the pancreas. When we assess for heteroplasmy, we can do that multiple ways. We can take blood samples, buccal swab samples for saliva, which was done in our patient. You can look at urine sediment, which is not done as commonly. You can also do muscle biopsies. This is, often set as the gold standard within the literature, although that may be more historical. And there have been studies that suggest that muscle heteroplasmy burden can be correlated with severity of RPE abnormalities. There has been work to look at the different grades you can have of MTTL1 disease. So there's 4 grades proposed. In grade 1, you can have very, very subtle pigmentary changes, would be very easy to miss on routine examination. In grade 2, you can have both areas of hypopigmented or hyperpigmented subretinal deposits that go on to encircle the disc. And often visual acuity is unaffected in these patients. Most have 20/20 vision. In grade 3, you can start to have very well delineated areas of chorioretinal atrophy outside of the fovea. So again, visual acuity can be preserved. And then in grade 4, the central fovea can also have this very profound chorioretinal atrophy, which corresponding decrease in BCVA. So in every grade by grade 4, the structure and function of the fovea itself is relatively spared, so you can have good visual acuity, but you can still have considerable visual impairment because of these pericentral scotomas. And one thing to note is that this paper used the term grade instead of stage, because at least in their follow-up, it's unclear if and how patients might present over time or change over time, and how the condition can evolve.
Ryan, that grade 1 is obviously very subtle, as you said, but
Yeah.
at grade 2, you can definitely appreciate how someone called this AMD.
Yeah.
You're not thinking about mitochondrial disease necessarily versus like, common things being common. You can definitely appreciate that.
Yeah, it's Brian jumping in here. I mean, many
Hmm.
of these patients who present to my clinic are of course younger patients, but often these deposits are characterized as atypical drusen or unusual appearing drusen that are hyperpigmented, or if they're confluent, they're described as focal PEDs or drusenoid PEDs. So, and of course, a family history of age-related macular degeneration is often thought of as a risk factor for AMD. So I don't think uh, pedigrees necessarily raise a flag. If a mother had a history of earlier onset AMD, then sometimes we might be quick to say, well, okay, well, if her AMD was earlier onset, maybe that's yours will be as well. But maybe something else entirely is going on. Ryan, you're doing a great job.
And this kind of goes to the point of what Dr. Ballas was saying. So he's had multiple cases of MTTL1 disease come through his clinic. And these photos highlight the broad spectrum of the type of presentations you can have where you have, case 2, maybe a bit more subtle appearing. It definitely on the fundus autofluorescence becomes more visible, and you can see it encircling the disc and would maybe raise questions of being not something like age-related macular degeneration. And then in case 1 and in case 3, you have these areas of chorioretinal atrophy that can either be isolated more within the macula or even extend beyond the macula. And in fact, all of these patients had a history of diabetes and hearing loss and had been diagnosed with early onset age-related macular degeneration. And there was also a very strong family history of diabetes and hearing loss. In addition to assessing heteroplasmy, in saliva or various sampling, you can look at histopathology with Gamori trichrome staining. I'm not sure if any of the residents or maybe could shout out what they think you might be looking for on Gamori trichrome staining in a mitochondrial disease, given that we just had the OCAP recently. There's kind of like a buzzword you think of, especially in CPEO, which we kind of read about more frequently for OCAP studying.
Red fibers.
Yeah, yeah, exactly. Ragged red fibers. That's perfect. And then you can also look at other stains such as succinate dehydrogenase, because you can get markedly proliferated mitochondria in this condition. And if it's in either muscle or endothelium, that can actually lead to decreased perfusion of organs over time. And then cytochrome oxidase as well, because that's a terminal enzyme in the mitochondrial respiratory chain. So what are the kind of broader clinical implications of this condition? Well, it's can truly be a very serious multisystemic disease. For neuro, you can have, such as our patients, stroke-like episodes. You can have seizures, renal impairment, cardiac with cardiomyopathies and arrhythmias. It's, not uncommon for these patients to have a family history of sudden cardiac death. GI problems, various endocrinology problems, not only the diabetes, can also affect pituitary function and adrenal function, hearing loss, myopathies. So you really need to help take care of the patient and connect them with the right specialist, the right screening for all these various potential systems and organs that can be impacted, and not only for the patient, but also screening of maternal relatives. And then this also leads to things to avoid, because there's certain medications that can make actually make them worse and exacerbate their symptoms. Diabetes, lots of patients are on metformin, but metformin actually increases the lactic acid burden within mitochondria, and it can make their symptoms worse, maybe even potentially cause an arrhythmia or lower their seizure threshold. Certain anti-epileptics, certain antibiotics, statins, you have to be careful with if the patient has myopathy. And in pregnancy as well, magnesium sulfate is used in preterm labor and also to prevent seizures due to worsening preeclampsia. But if you give magnesium sulfate to one of these patients, you may in turn be lowering their seizure threshold. So it's really important to kind of identify these conditions because it can be very preventative for the patient in the future. Now, just looking at the time, I won't go into too much detail in these other conditions, but just important to keep in mind that there's many mitochondrial ophthalmic diseases that include, mid and MELAS and retinopathies, different other retinopathies, neuroophthalmic presentations, Leber's, dominant optic atrophy, CPEO, and also more complex multifactorial disorders such as diabetes, glaucoma, and AMD. And then when we think about late onset retinopathy with a macular focus, that also has a very broad differential as well, from hereditary like MTTL1 that we talked about today, ABCA4 related disease, PRPH2, some of the pattern dystrophies, RPE65 associated. And you can also think of acquired conditions as well, myopic degeneration, which we can relatively frequently see in our clinics, medication toxicity, Plaquenil, Pentosan, paraneoplastic autoimmune retinopathy, infectious or inflammatory causes, TB, syphilis. So there's quite a broad differential to think of and keep in the back of your mind. So some take-home points. We want to avoid anchoring. If a patient comes in with a diagnosis, try to approach it with a fresh set of eyes and beware of early onset age-related macular degeneration. You want to take a comprehensive personal and family history. Do not ignore comorbidities, even as common as they may seem, such as diabetes, hearing loss, and stroke, especially in a younger patient. And always consider mimickers, hereditary and acquired. Thank you.
Thanks, Ryan. That was terrific. You really summarized the case really well. And I think, if you just leave up your take-home points, I mean, I'm seeing, this your point number one, avoid anchoring, I think is so important. And it's true in retina, and it's true in any subspecialty. I think we all have to avoid our intrinsic bias or, a referral diagnosis that comes from a referring provider, to think carefully about what it really means. Age-related macular degeneration is by definition a disease that's age-related. That's how it's defined. And when someone comes in their 40s, with a diagnosis of early onset age-related macular degeneration, it has to raise a red flag. You have to think to yourself, well, right, but we can't forget all of the other possibilities of what this could be. And as you very well highlighted, a lot of the comorbidities here are quite common comorbidities in our eye clinics, and many that we'd probably be quick to understand and account for, but then sort of dismiss as being related. And it's remarkable now how many of these early onset AMD cases, so-called early onset AMD cases, are being identified as being related to hereditary disorders, and they have profound implications for the health of our patients and how they need to be connected with their providers, what medications they can and can't take. And, some of these patients with cardiac issues, they can have sudden arrhythmias and heart blocks that can lead to sudden cardiac death. And if they're on the wrong medications, it can lower their threshold for that. So these are very important conditions to keep in the back of our minds. And I think if we all reflect on our practices, and certainly when I think back to training as a resident and even as a fellow and looking at patients, I wonder about how many younger patients with early onset AMD I saw who may have actually been walking around with mitochondrial variants causing this. And you pointed to some of the statistics. So do we have any questions before we move to the next case?
I was just going to add, Brian, they're great cases and great presentation, Ryan. But, the imaging was fantastic that you showed. And, I find, some of the things that kind of point to a diagnosis of a mitochondrial disease are the, patients that can't hear you. They constantly ask you to repeat what you've said. And if you look at those, if you look at the color fundus photos and, the picture you get when you look into the back of the eye, they're much less impressive than the autofluorescence pictures. Like, nobody would miss, something abnormal in those autofluorescence images. But the other point I was going to make, I have a handful of patients like this that I follow, and they certainly lose vision from their mitochondrial disease, but Brian or anyone else, they don't really get diabetic retinopathy. They're diabetic, but I haven't seen any with, diabetic macular edema or proliferative diabetic retinopathy. They seem to very rarely require treatment for their diabetic retinopathy. I don't know if your experience is any different. I don't know if this helps to protect them from diabetic retinopathy, but they don't typically lose vision from diabetic retinopathy in my experience.
I agree. I haven't seen in these cases any significant degree of diabetic retinopathy. I can think of one case where I remember some dot heme in the far periphery, but in general, I haven't seen anything that advances or diabetic macular edema or other sequelae of diabetes. And it's an interesting hypothesis to think that maybe there's something protective, or as Ryan pointed out, many of these cases may not be the same kind of beta cell and insulin resistance pathology or pathogenesis of diabetes as we think of. A lot of these patients have relatively normal BMI, and their metabolic dysfunction of their beta cells is driven by their mitochondrial dysfunction and metabolic dysfunction, and maybe it's fundamentally a very different disorder, and that changes how susceptible their retina is to those changes. But I think it's not very well resolved. But I agree with you. I don't see diabetic retinopathy commonly. And you're right, on a fundus autofluorescence, it can be very, this obviously looks quite unusual for something called age-related macular degeneration, and those changes can be subtle. And I guess a big thing is to just think about your demographic when you see those fundus changes in a 40-year-old, then you have to think, well, maybe I won't conclude it's AMD. I should see if this patient should have some multimodal imaging, and these imaging modalities are becoming far more accessible and common to providers everywhere. So digging deeper on those patients is, even with the family history and thinking of risk factors, probably important.
And the other question I had, Brian, was, when you're sending a patient for genetic testing and you're suspecting a mitochondrial disease, do you have to do anything different, or do you just ask for a mitochondria panel, or or is this part of, the usual genetic screening profile that gets done automatically?
Well, no, it doesn't get done automatically, and you have to think carefully about what lab is going to assist you in doing your sequencing. I like to keep a broad, like an open mind with these cases, and that it, as Ryan highlighted, there's a long, even hereditary differential, but not all labs offer mitochondrial sequencing as part of their genetic testing. And so you have to dig deep into what the lab is really going to offer, and some what might be called inherited retinal disease panels that you could click and order from some labs won't include any sequencing of the mitochondrial genome. So you do have to be cognizant of that possibility and make sure that you're ordering a test that includes it. It's not easy to sequence the mitochondrial genome and get estimates of heteroplasmy. Some labs can do it really well, and because it's not as easy, some labs don't offer it as part of their screening panels.
Thank you, Ryan.
Thanks.
Ryan, great presentation. We'll move on to Saba.
Hello, can you see my screen? I'm not sure if you guys can see my screen.
Yes, we can see it, Saba.
Oh, okay, thank you. My name is Saba. I'm one of the PGY4s, and I'll be presenting the second case with Dr. Ballios. Maybe one of the hints that Ryan threw in his presentation may help with this case. We'll see. So this is a case of a patient, a 13-year-old female referred from a neuro-ophthalmology colleague for bilateral low vision. The patient reports that she's had trouble seeing in the dark, especially since she was born. She reported prolonged dark adaptation and difficulty with transitioning from well-lit to dimly lit illuminated spaces. Her parents reported that as a young child, she preferred looking towards bright light like the sun, ceiling, or lamps. The patient reported poor central vision, but stability over the past 5 to 6 years. She also had some challenges with her peripheral vision, especially in dim conditions. She noticed like her brother could easily sneak up on her easily from the side. She's never had roving eye movements or nystagmus. Her past ocular and medical history were unremarkable, and the family history wasn't too remarkable either. Her brother had no concerns. She had a paternal cousin with congenital color blindness, but otherwise nothing that stood out, and she has no history of consanguinity in her family. So the patient had seen an ophthalmologist back home without a diagnosis and was then seen at the Mayo Clinic 5 years prior with the diagnosis of query CSNB. She and her family then moved to Canada and saw neuro-ophthalmology for consultation, who reported vision of 20/50 and 20/60 at the time, and a normal fundus exam. So she was then referred to Dr. Ballios for further investigation. So on her exam, her vision was pinholed to 2200 and 2100. She had normal pressure. She had poorly reactive pupils, but no REPD. I'll quickly go over the fundus exam here. It's symmetric in both eyes. She had normal discs, but there is some vessel attenuation in both eyes. And the macular pigmentation was normal, but it's a bit hard to see here. The periphery, she actually had gross diffuse peripheral retinal hypopigmentation and atrophy with absence of hyperpigmentation. So we moved on to doing some ancillary testing. Here we did fundus autofluorescence and OCTs. If a resident wouldn't mind maybe telling us, do they think the FAF and OCT looks normal or abnormal, or if anything stands out to them, can they tell us what they see?
Maybe a PGY 3 or 4. Not all at once, though.
Jacob?
Sure. So the fundus autofluorescence looks globally diminished. I don't see any clear like vasculature or foveal zone on the OCT. I think the most obvious is that the ELM appears a little bit diminished as well, and the ellipsoid zone is not as clear. Like there's like a mottled appearance to it.
Yeah, perfect. So here the patient has globally diminished fundus autofluorescence in both eyes, and there is still some diffuse preserved autofluorescence signal in the central macula. And then on Heidelberg spectralis OCT, on first glance, it may not seem like there's anything wrong, but we actually see the patient does have preserved foveal lamination, but they have indistinct outer retinal banding, like you said. The ELM and the ellipsoid zone are particularly attenuated in the periphery of the macula. There's a preserved outer nuclear layer thickness in the fovea, but it does tend to thin out in the periphery. And the inner retinal banding that we can see in the fovea is suggestive of incomplete formation of the foveal exclusion zone, because you would expect less inner retinal bands right at the fovea. And to give you a comparison, because sometimes once you see the normal, you realize where the abnormalities lie. This is a normal FAF. You would expect much more signal on FAF here that the patient doesn't have. And when an OCT doesn't look like a normal templated OCT, then we say it's abnormal. So here we can see the ONL is the only layer we can see here. So that is abnormal. And in the periphery, the ELM and the ellipsoid zone are lost. So her FAF and OCT are actually not normal. So I think we have a first poll question, if Dr. I could pull them up. Are there any further investigations you would order? Visual fields, electroretinogram, genetics panel, MRI brain, or we don't want any further testing?
We'll give it a second to run there.
Mm-hmm.
So the majority want an ERG, but there's some support for visual field and a genetics panel as well.
Perfect. So we will do most of these in the workup. We won't need an MRI brain at this point. So the next test we did was the Goldman visual fields. You can see the right and left eye here. So we can see mild generalized constriction in the green 1,4E zone, and there are some mid-peripheral defects. The interpretation of the field is exactly as the patient said, that she has mid-peripheral relative scotomas in both eyes, which are present in dim illumination, but in bright illumination, she actually has a full field. So this nicely matches the patient's symptoms that she was describing. The next test that we did, like was guessed, is the ERG. So on full field ERG, we see non-detectable rod isolated response amplitudes. And for those of us who don't see much ERGs, this is a more relative one that we would expect for the patient. This is the combined rod cone response, and we can see also that the cone rod response is also minimally preserved with reduced amplitudes and a delayed peak. This is what we would expect normally with an A wave and a B wave, but for her it's quite flat. And lastly, the cone isolated 30 Hertz response is detectable, but it's significantly reduced in amplitude and delayed in timing. And this is what we would expect in a normal person. So the ERG results were the same in each eye. And when we compare to a normal ERG in green, we see both her rod and her cone responses on ERG are completely absent. So these findings are consistent with generalized retinal dysfunction affecting the rod and cone photoreceptor system. So then we moved on to doing a multifocal ERG with 61 hexagons to assess her macular function. The response from both eyes we see here are essentially not measurable above noise from any tested macular region. So the individual responses that we see here are flat throughout, and it basically gives us a response density topograph here that doesn't have a central peak at the fovea. And if we look at the ring amplitudes here, they are flat and they're below the normal range we would expect. This is a more normal multifocal ERG for your comparison to see the bilateral macular dysfunction with the foveal involvement without the peak that we're seeing in this patient. So multifocal ERG in this setting here is quite valuable because it's showing, despite her relatively preserved macular structure on OCT, she essentially has no detectable macular function on ERG. So it really highlights a structure function dissociation here in our patients. That's another clue on what's going on. So we have our last poll question here. If people want to guess what the diagnosis is it CSMB? Is it retinitis pigmentosa, achromatopsia, or Leber congenital amaurosis?
We'll give it just a second to run here. I was a little late launching it. Okay, you've got a bit of a mix here, Saba.
Okay, that's great. So to summarize our patient, we can say that we see basically significant structure function dissociation. Specifically, her exam shows almost normal appearing fundus with only subtle changes. She has preserved outer retinal lamination on OCT. She has profoundly reduced global FAF and low to absent ERG response amplitudes that typify a number of inherited retinal dystrophies.
Saba, before you continue, I'll jump in there. CSNB, as you mentioned earlier, was the anchoring diagnosis. That was the diagnosis that had been given to her when she was younger, as you mentioned at the Mayo, because of her issues with night vision problems. And I know you're going to get to it later on the theme of anchoring, but there might also be some clues in addition to the anatomic clues that might suggest that CSNB should be treated with some skepticism. And one of the clues might be the fact that she's complaining of progression of her disorder through her childhood and into her young teens, age 13. And right in the name of CSNB, this is a stationary disorder, right? This is a disorder that we expect patients not to experience progression over time, and yet she's experiencing progression. So even knowing nothing else about the case, hearing a patient coming in with progressive issues with their vision and hearing an anchoring diagnosis of CSNB, already perhaps a red flag comes up to say, should we be thinking that or some others? But I'm glad you gave this particular list, which is problematic for other reasons you'll explain.
Yep. So importantly, these findings summarized are actually distinct from CSMB, where you would not only see that it's not stationary in this patient, but in CSMB, you would expect an electronegative waveform where they would have an A wave still, but a diminished B wave. As well, they would have preserved photopic responses, and they would have more of a normal OCT and FAF on imaging. So our patient actually doesn't meet the clinical criteria for CSMB that she was diagnosed with originally. With retinitis pigmentosa, you would expect more relative rod dysfunction, and as well the OCT, you would expect more macular atrophy and thinning. With achromatopsia, achromats have preserved rod function and absent cone function. So it's also more of a stationary disorder, but our patient has some progression, like we said. This is actually a trick question. It's actually not also Leber congenital amaurosis because with LCA, you would expect much more profound vision loss from birth. Our patient is in her teenage years, and she's actually been functioning and attending school with only some difficulty. So our patient actually has an early onset retinal dystrophy, and more specifically with the profound globally diminished FAF, it would suggest that the disruption in her case may possibly lie in an enzyme important for visual pigment cycling. And so at this point, we had a strong suspicion for the diagnosis, but we proceeded with genetic testing with the family first to confirm the suspected diagnosis we had. So the patient, her mother, and her father underwent genetic testing for her retinal dystrophy, and it was found that the patient is heterozygous for this RPE65C74 mutation from her maternal side and the 1338 mutation from her paternal side, which are both pathogenic variants. So the patient therefore has a clinical diagnosis of RPE65-associated early onset retinal dystrophy. So the genetic results are consistent with many of the features that we noted on her clinical exam and the structure-function dissociation. Leber congenital amaurosis, or LCA, secondary to RPE65 mutation, and RPE65 early onset retinal dystrophy are actually part of the same disease spectrum, with the latter that our patient has being less severe, with later onset of visual impairment and often better preserved visual acuity. So this molecular result is consistent with disruption of the RPE65 enzyme, which is a key enzyme important for visual pigment cycling. The 74C variant is known to be hypomorphic, so it means that it's less anatomically severe. So patients are often less profoundly affected than someone with RPE65-associated LCA from a different mutation. Because it's relevant, I'll quickly go over LCA. LCA is basically a family of congenital retinal dystrophies that result in severe vision loss at an early age. They can have nystagmus, sluggish pupils, and very severely decreased visual acuity. There's various retinal presentations and phenotypes with at least 29 genotypes, and there's still more genes to be identified. So it's a heterogeneous recessive disease. The pathophysiology is related to inability of the eye to undergo phototransduction because of a disruption in the visual cycle. So what is the visual cycle? It's basically a series of enzymatic reactions in the RPE where from the dietary vitamin A, 11-cis retinal is produced to generate photopigment. So if you don't have 11-cis retinal, the phototransduction cascade can't be initialized. So a dysfunctional mutation in any of the genes encoding for proteins to generate vitamin A to 11-cis retinal can lead to symptoms of LCA or early onset retinal dystrophy. Just some history, it was actually a German ophthalmologist, Theodor Leber, that Ryan also mentioned, that first described the dystrophy in a child with nystagmus and amaurotic pupils and congenital RP in 1869. And in 1957, an abolished ERG was identified as a common feature essential to diagnosis of LCA. He's actually the same person that described LHON and Leber miliary aneurysm, so he was a very busy man. Our patient here doesn't have the severity of presentation that we would see with LCA. Usually LCA patients are legally blind and they have no sensitivity to stimuli from birth. Our patient is along the milder spectrum of early onset retinal dystrophy with mutation in the RPE65 enzyme that can also cause LCA. So these are the symptoms and signs in RPE65 early onset retinal dystrophy, and the more severe ones can be seen in LCA. The green ones are the ones that our patient has, so they can have nyctalopia, prolonged dark adaptation, photophobia, eye rubbing. They can develop keratoconus and ophthalmos secondary as well. They have light-seeking behavior that she had. They can have diminished visual acuity, but it tends to be stable or slowly progressive. They can have hyperopia from poor emmetropization in childhood. Our patient didn't have the severity of paradoxical pupils or mobility issues, but she did have some vessel attenuation, global FAF reduction, and the extinguished ERG. The retina sometimes can be a little unremarkable, but in late phases, they can have vessel attenuation and chorioretinal degeneration. So what's exciting about RPE65-associated LCA or early onset retinal dystrophy is that in this area, we have had advancements in therapeutics developed with gene therapy. So in 2017, the FDA approved voretigene neparvovec, or Luxturna, that was developed by Spark in Philadelphia. In Canada, Luxturna is distributed by Novartis. So Luxturna is specifically indicated for treatment of adult and pediatric patients with vision loss from biallelic RPE65 mutation-associated retinal dystrophy, and who also have sufficient viable retinal cells. So we'll go over that criteria in a second. This is actually the first FDA-approved in vivo gene therapy, not only for the eye, but among all genetic diseases. So the key eligibility requirement for Luxturna is summarized here. So for our patient, she does have confirmed to have 2 pathogenic variants in RPE65 inherited by each parent that we identified by testing with Blueprint Genetics. For our patient, there is also evidence of macular photoreceptor outer retinal integrity on OCT in both eyes. And a full field threshold sensitivity study, or FST study, was also organized to be done at SickKids, which she passed, and I'll go over this test in a second. And our patient is also above 4 years of age, so she does meet the eligibility criteria. So the FST was actually made for the Luxturna gene therapy trials to measure gross retinal sensitivity. In the trials, they basically needed a functional subjective endpoint that didn't depend on standard psychophysical tests that we usually use, like visual field or visual acuity chart, because these patients with inherited retinal dystrophy can have profoundly low vision. So reading a visual acuity chart or standard fields may not make sense for them. So the FST basically determines the lowest luminance flash that will elicit a visual sensation that's perceived by the patient. So it's a good measure of a threshold for gross retinal sensitivity. The test can be done in dark or light adapted conditions. It can use different colors, so it can assess both rod and cone function. It's also not affected by nystagmus, which a lot of these patients have. So in these patients, it's a better test of telling you whether they have sufficient viable retinal cells, which our patient does have. So once you determine the patient meets the eligibility criteria for Luxturna, then they can be considered for treatment. So what is Luxturna? Luxturna is basically a suspension of adeno-associated viral vector, or AAV2. It has been genetically modified to express the RPE65 gene using recombinant DNA. So the suspension of AAV2 is injected into the subretinal space where the RPE cells, now with a functioning gene, can produce the RPE65 protein to restore the visual cycle. So if we go into the breakdown of how it works, the viral vector is basically injected into the subretinal space to form a bleb. The vector carries a functional copy of the RPE65 gene to the RPE cells beneath the formed bleb. Then the vector is taken up into the RPE cell via an endosome, and then it binds to the nucleus and releases the content into the nucleus. The DNA that's released then forms a circular episome, and the cell then expresses this functional RPE65 protein. So why is AAV, or adeno-associated virus, a good candidate for this? It's basically a non-pathogenic, predominantly episomal vector, and it was chosen for several reasons. So one, episomal vectors exist outside the host genome. So they're less likely than integrating vectors to perturb the normal expression of the host gene. They're also capable, in fact, of infecting both dividing and non-dividing cells. They can be made in high titers, and you can develop different isotypes for different targets. So there's serotypes for the pancreas, liver, CNS, heart, and also for the retina. They do have a limited carrying capacity, though, of 5 kilobytes. So the gene candidates may be limited, but the RPE65 gene is an appropriately sized gene to fit within the carrying capacity of AAV2. So RPE65 is a critical visual pigment component in the visual cycle. Once the cell can make the functional RPE65 protein from the gene, then 11-cis retinal is now able to be regenerated. And so the visual cycle can be restored to allow the retina to respond to light. Looking at the actual surgical injection, we consider the retinal pathology, anatomy, and ease of accessibility. So the surgeon usually avoids pathologic features like intraretinal pigment migration or dense atrophy because you want to be close to functional RPE cells. We also avoid direct contact with the retinal vasculature to limit bleeding complications. So once a vitrectomy is done, then 0.3 milliliter of the suspension.
Saba, just because we're running a little low on time, I think you might have a video showing the procedure that might be more illustrative, courtesy of our chair, Dr. Peter Curtis.
Yeah, so the 0.3 milliliter is injected subretinally, and we have a video of Dr. Curtis doing the injection here. So it's a standard 3-part vitrectomy. You inject analog to help induce the PVD.
Saba, while we're watching the video, which has the labels, I'll just say that to the group that when we were reviewing this case with Saba, and I was talking about it, and I said, gene therapy going. She says, oh yeah, I've been in the OR with Dr. Peter Curtis and Dr. Rajiv Mooney, and I've probably seen like 4 of these injections. And the way that she said it made me feel so happy, because I thought, don't we live in this remarkable age where trainees are seeing this incredible type of procedure done, gene therapy in living people, and they see it as like any other day in the OR for patients. And I think that's our hope, that'll be the future for treatment for a lot of these inherited retinal diseases, right? This will just become kind of a commonplace type of treatment as these therapies expand to other genes. But I just thought that was just such a great way of expressing, something which is quite a profound thing that's being done to these patients who, by all rights, should not have any improvement in their visual function at all, given their genetic disorder.
It also makes me feel old, because this was like the future when I was a resident, and it's here. It's amazing.
I gotta say, I remain pretty excited about these cases.
It's very exciting.
So you can, Dr. Curtis raised two blebs in the posterior pole to try to sandwich the macula and the fovea, so that the vector could access all of the RPE and photoreceptors through the posterior pole, where we'd like to preserve the visual function.
Yeah, so looking at the original Luxturna studies, the first phase 3 trial was from Russell et al. In 2017, assessing 1-year outcomes in relevant functional measures, including the FST that I went over before, as well as multi-luminance mobility testing, or the MLMT, which I'll go over. So the MLMT and its development is very interesting. So in response to the, did my video stop? There we go. So in response to the need for relevant and clinically meaningful measure of functional vision in these low vision patients with nyctalopia, members of the study, with input from the FDA, actually developed the MLMT for this study. It's basically a 5-foot by 10-foot obstacle course surrounded by a 1-foot border that evaluates the individual's ability to navigate in different luminance settings. So this is like a luminance for, let's say, a parking lot at night that someone with normal vision would be able to navigate. But we see here that this patient is having some difficulty and actually will need some redirecting as she goes off course. She's also less confident with movement and is not going with particular speed. So it is a better functional measure than visual acuity or visual field that we normally would do in studies. So here it takes her quite some time, and she also loses the door in the end. So after the patient gets the Luxturna vector administration, we get a significant improvement in her navigation ability in low light conditions. So she's moving with much more confidence, speed, and accuracy. So in this study, the masked graders then evaluated the changes in MLMT between Luxturna group and the intervention. So here we can obviously see that she's doing much better after the Luxturna injection.
That is
So
truly amazing.
Yeah. So if we go over the results, we see the MLMT score and the change in MLMT score here. In the original 2017 study, it was done up to 1 year, and the controls are in orange, and the intervention with Luxturna is in green. So you can see improvement within 30 days after subretinal delivery. So it is quite fast. The study showed clinically meaningful and statistically significant improvement in ability to navigate independently in intervention group with Luxturna compared to controls. And then here, after 1 year, the controls were crossed over. So they also got Luxturna and they got the same amount of improvement. And they looked at durability of the effect, and it looks like it has maintained its durability for the 5 years that it's been studied for so far. After the first year, one person had 6 patients had a change of 1 light level. None of them went below pre-treatment levels, and there was no change in the remaining 20 with an N of 26. So this shows durability of the effect with Luxturna in improvement in function for up to 5 years. And we saw the same results with the FST score that I went over before with the Luminance study. So these as well showed improvement, and after 1 year, the controls also got the injection and showed improvement in their FST testing. So they are continuing to be assessed actually for the next 15 years. So there will be more results in long-term outcomes in the future. So going back to our case, we conclude the patient doesn't have CSMB, but she has RP65 associated early onset retinal dystrophy. We reviewed the RP65 mutation doesn't always lead to the severe presentation of LCA, and there's a spectrum of disease depending on the mutation, but any biallelic RP65 mutation is eligible for gene therapy regardless. So our patient was referred and is pending treatment with Luxturna. It's important to find and identify these cases because there is potential for treatment, and better yet, there are more therapies on the horizon. So this chart shows a selection of ongoing ocular trials using the adeno-associated vector for other inherited retinal dystrophies. So there will be more in development. And this shows the Canadian treatment network where we see a lot of familiar names where these treatments are being developed and being done. So it's really a pan-Canadian effort for developing centers of excellence in inherited retinal dystrophy. And you can see a lot of familiar faces on the map here. So thank you to Dr. Ballios as well and Dr. Wright for the case.
Thanks, Saba. That was terrific and such an important case to highlight in any grand rounds we do on inherited retinal disease, of course. So any questions from the audience?
Not a question, but a comment. I think, Saba made a great point there at the end, just about getting these folks identified and, into retina clinics and potentially getting their genetic studies done. Because there's so much, we're actually at a point now where we might be able to help these folks, and, having them readily categorized or available on our EMRs will just expedite their ability to participate in a study or even a therapeutic intervention. So I think it's a great point for the non-retina specialists out there that we can help these folks just navigate the system a bit. And that video of that functionality of that patient walking, I think is, it's truly incredible, the change that she had there.
It's remarkable to see patients who've been treated in clinic afterwards. I mean, to watch their visual function improve, to see the improvements when in most clinics in inherited retinal disease, as patients come year to year, you're seeing gradual diminishment of visual function. To see them go in the opposite direction it feels like science fiction. It feels like it makes no sense. It's like you shouldn't be seeing this, but it's incredible, and the life-changing effect it has on people. So the case is to keep an open mind, right? To know that maybe if a patient doesn't have what sounds like Leber's, that they may still have an intervenable retinal dystrophy and still deserve evaluation, even if they're not fitting the perfect clinical picture. We know it's not a treatment for Leber's, it's a treatment for RPE65 genetic disease. So you have to get to that molecular diagnosis.
So we'll wrap it up here. We're a couple minutes over, but I do want to thank Saba and Ryan for the wonderful presentations, and Brian Ballios for coordinating all of that this morning. We don't have grand rounds next week in lieu of Good Friday, so we'll see you guys in a couple weeks. I hope everyone has a great weekend.
Thank you.
Thank you.